Good afternoon, everyone. Today I'm going to present a case highlighting the difficulty that we face in the cataract surgery. A 75-year-old male came to us with the complaints of defective vision in his left eye for past 2 months. It was insidious in onset and progressive in nature. There was history of cataract surgery 2 months back. He has been using eye drops NaCl 5% since then, and then he was referred to us when no improvement was seen. There was no history of trauma, pain or redness, and there was no systemic illness. On examination, right eye vision was 624 and other parameters were within normal limit, whereas left eye vision was finger counting close to face, and cornea showed epithelial edema with Decimate membrane folds with diffuse stromal edema, and there was a superior large DMD which was extending temporally. This was the picture which was taken when the patient came to us. I have tried to represent it through a handmade diagram. We performed an AIOS2025, and as you can see, there was a complete DMD which was superior in location and was extending temporally. On taking a treatment history, patient was initially kept on conservative management. He was started on topical corticosteroids, hyperosmotics, that is NaCl 5% drop 6 times and 6% ointment at bedtime. He was also kept on cycloplegics. Since he was not showing any improvement for past 2 months, he was advised to undergo desmetopexy with C3F8 gas. This is the video in which we performed desmetopexy. A side port was made, and then after forming the chamber, we had performed an inferior peripheral iridectomy and C3F8 gas was injected. After 2 hours of procedure, intraocular pressure was checked and it was found to be within normal limits. This was the picture preoperatively when the vision was finger counting close to face, whereas this was the image which was taken on post-op day 1, where vision significantly improved to 2/60. Discussing on DMD, as we all know, DMD is a diffuse corneal edema with slit lamp evidence of DM separation from posterior stroma at the site of corneal edema, as we can see in the diagram. Going to the epidemiology part, it is most common among the cataract surgeries. It has a high percentage in SICS, which is about 1.5% as compared to phaco, which is 0.5%. Gonioscopy incidence is 11 to 42%, whereas unreported small subclinical detachments we are not able to report because they resolve spontaneously within days after surgery. Clinical presentation is normally decreased vision, watering and photophobia, and signs are non-clearing corneal edema with slit lamp evidence of DM separation. Risk factors for DM are patient-related factors, intraoperative factors, and post-operative factors. Factors which lead to DMD during small incision cataract surgery. This is the main part which I want to focus. Patient-related factors, which can be shallow anterior chamber or pseudo-exfoliation, dense cataract or deep socket. The steps in which commonly DMD occur, which had happened to me in many cases, is during AC entry with keratome, during OVD insertion, or during nucleus delivery. And how can I prevent that? By proper preoperative workup, by proper handling of instruments near tunnel area and side port, and by slowly delivering the nucleus with enough viscoelastics. Classifying DMD, it can be either loose or taut. Loose part can be divided into unscrolled and scrolled, and unscrolled can be planar or non-planar. Another classification is the Duas classification. Management options. It depends on the following factors: size of DMD, whether visual axis is involved or not, scrolled, unscrolled, taut or loose. If it is a planar, unscrolled and loose DMD, we prefer not to do anything and we leave alone, just keeping the patient on conservative management, and anti-glaucoma medications can be added if required. In all other types of DMD, either we can do a manual repositioning, which is done via cyclodialysis spatula, Decimate membrane suturing, or we can do a desmetopexy, which we did in my case, where we can use gases like 100% air, which lasts for 3 to 4 days, hence it is least effective. 14% perfluoropropane C3F8, which lasts for up to 6 weeks, and 20% SF6, which lasts up to 2 weeks. Combination of anterior chamber gas injection plus surgical repair. These are the some literature reviews, some studies which showed the effectiveness of desmetopexy. Another study which was published in the Journal of Cataract and Refractive Surgery. Thus, one more study is there which shows slit lamp based management algorithm, which again based on the classification helps us to decide whether we have to use air or we have to use SF6 or C3F8. In all cases, if the last resort when desmetopexy is failing is either to perform a penetrating keratoplasty or a desmet stripping endothelial keratoplasty. Thus concluding, I can say that DMD is a vision-threatening complication of cataract surgery. Most are unrecognized and get spontaneously attached. Risk factors of DMD should be recognized and careful instrument handling should be done. For beginners during cataract surgery, anterior chamber injection of gas is the treatment of choice, and repeat desmetopexy should be performed before keratoplasty. Thank you.